Okay, thank you very much. I think that most of the things that I should say have already been explained by Eric Weiner. So that's great because, in fact, I will move very quickly to clinical cases. Out of that, my focus today is concerning the young age. Although, if you observe, the two cases are much more concerned, and that's my interest, on the neoadjuvant setting, a particular setting where, hypothetically, Oncotype has not been validated, although I think that it's a very exciting scenario based on the data from tailoring to use it. My disclosures, and that's my first case, okay? That's a female, 48 years old, premenopausal, with no comorbidities, with a left breast mass by exploration. The mammogram and the ultrasound found a BRAF 4B, 3.6 centimeter mass with no axillary involvement, and the biopsy showed an infiltrating ductal carcinoma, grade 2, ER 80% positive, progesterone receptor 60%, Ki67 20%, HER2 negative. So as T2 and 0, luminal early breast cancer. And my first question, what will be your personal recommendation for these patients in the absence of a multigen assay test? So 3 options, obviously 3-1. I will mention that in my country, in Spain, over the last 5 years, in this case scenario, about 80% of clinicians will vote for chemotherapy. Okay. That's not the case in this room. Just 30% will vote for neoadjuvant chemotherapy, 10% for neoadjuvant endocrine therapy that, at least in Spain, is not considered a reasonable option. We can discuss further. So we go for the next question, the same case, but what if you have access to multigen assay? You will consider these patients as a good candidate for the test before surgery, or you will go directly through surgery or neoadjuvant treatment as you decided before. So about 40% of you will ask for a multigen assay before the final decision. So this patient entered in a program that I will show you later, in which we have the option to perform the Oncotype recurrence score, and with this clinical profile, the patient had a recurrence score of 23. So the next question, what will be your recommendation following the clinical data and also the recurrence score result? Okay, so little changes, although neoadjuvant chemotherapy has dropped a little bit, but the vast majority of you will continue on surgery. I didn't ask about what will follow surgery, but it is clear that the data from the TAILOR-X had shown that patients with recurrence score lower than 25 have no benefit from chemotherapy when they are older than 50. But there is this question about patients, younger patients with a recurrence score in between 21 to 25, in which, although it's marginal, the benefit is around 6%. So it's in a scenario where you still could consider that chemotherapy would have some benefit, and that was the case for this patient. I will explain. The patient received chemotherapy, recommended her to follow the marginal benefit from Oncotype. The patient received neoadjuvant chemotherapy with cisplatin, with TC times 4. She underwent surgery. At surgery, there was a T1 and 0, and the patient continued on endocrine therapy for 5 years, as well as radiotherapy. Okay. We have some data suggesting that this cutoff of the age is also important by a clinician's perspective. Those are the cell register with real-life data from patients undergoing molecular phenotypes. And the interesting tool about this data is that out of the results from the recurrence score, the major driver for defining chemotherapy was the age. So younger patients were more exposed to chemotherapy, whatever the result of the recurrence score. So meaning that this is a very important issue in clinical practice out of the definitive results of the molecular platform. In Spain, we have access to the different platforms, but the access is regulated, as Dr. Weiner presented for his center. In all regions, it depends on the reimbursement, but it's generally limited to T1, T2, and 0 with low-grade pathological aspects, low-grade or low Ki-67. So, in fact, what we conducted is a study with 230 patients in which we allowed these centers who have the platform for these low-risk patients to perform the platform for patients at the risk where they were not reimbursed. So 3 groups, one for node negative with aggressive phenotypes, high-grade, high Ki-67, the second for N1 tumors, but with low aggressive phenotypes, Ki-67 lower than 30%, and the third in the neoadjuvant setting. This is a study that we will present the results at ESMO Breast. We were not on time to present here. I will just mention one thing. In the subgroup with neoadjuvant treatment, the number of patients that finally skip chemotherapy was 74%. So 3 out of 4 patients were not treated with chemotherapy based on the results when they have the initial decision by the breast cancer committee to receive chemotherapy. I show you a second case. Okay, again in the neoadjuvant setting. This is a 53 years old, postmenopausal, but for me still young, no comorbidities, a right breast mass. The mammogram and ultrasound found also a very suspect lesion, 4.5 centimeters mass, with one suspect axillary node. Although the axillary node was also punctured, it was negative. It's because of that I was able to perform the test. The biopsy showed that it was an infiltrating ductal carcinoma, grade 1, estrogen receptor, progesterone receptors positive, Ki-67 20%, HER2 negative. The 21 gen assay result showed a recurrence score of 16. What would be your recommendation following the recurrence score test? Okay, so it's still debatable, this, based on the results. This patient underwent surgery, so she had a surgery as first treatment. In fact, the surgery with a mastectomy, because the patient had two tumoral foci, and axillary dissection. It showed a T2, 47 millimeters, and one with 2 lymph nodes involved, M0. So if surgery was the primary treatment, what will be your recommendation for this patient with a T2 and 1? Remember, recurrence score of 16 based on that. Chemo followed by endocrine therapy, exclusive endocrine therapy, or not sure. Okay, so still people are not so confident on the recurrence score for node-positive patients. I will tell you this patient, it was one of my very early patients in this study. After surgery, she underwent just endocrine therapy, and 3 years later, so 2 months ago, we identified a second tumor. She presented a pancreatic neuroendocrine tumor that when we were performing the CT scan for reconstruction, we found a T1N0 neuroendocrine tumor. The patient has undergone surgery, and she continues on letrozole as adjuvant treatment, but no chemotherapy at all, and the patient is doing quite well. And just to conclude, I think that honestly, in young patients, it's still a major criteria to decide chemotherapy. In Europe, a large number of those patients with large tumors are submitted to neoadjuvant chemotherapy as a standard of care. The tailoring has shown a consistent lack of benefit for patients with recurrence score lower than 20, even in young patients. And all the data that I have not shown you is that there are studies that correlate as the intratumor heterogeneity is not a problem. The validity of the recurrence score is reproducible, whatever in a biopsy on the final surgery. So it will not change, although we are doing several trials in this way. So the preoperative recurrence score may be very helpful for these patients that at some point we are dubious about the validity of chemotherapy, whatever in the neoadjuvant treatment or in the adjuvant treatment, to reduce her risk for breast cancer relapse. Thank you.